Spinella, myself, and the rest of BloodNet, I'd like to welcome you all to ongoing debates on extracorporeal membrane oxygenation and anticoagulation. So the learning objectives of this webinar, Michelle, if you could advance, are to identify choices of anticoagulation during ECMO and the advantages and challenges of each method, to discuss approaches to anticoagulation testing and monitoring during ECMO, and to learn about circuit-dependent effects on thrombosis and hemostasis. We're very honored to have 4 excellent sessions with really excellent speakers who will be leading us through these objectives over the next 2 hours. And yes, we will be also planning to record the session. So first we'll have Dr. Ali McMichael, who will talk to us about choices of anticoagulation during ECMO, followed by Caroline Osment, who will present approaches to anticoagulation testing and monitoring during ECMO. And then Dr. Susan Shea, who will discuss ECMO circuit-dependent effects on hemostasis. And then finally, we'll conclude with a question and answer session moderated by Dr. Ryan Barbaro. So each of these sessions will be approximately 30 minutes long, and we'll ask you all to hold your questions until the question and answer session. So with that, I'd like to introduce our first speaker, Dr. Ali McMichael. Dr. McMichael is an assistant clinical professor in pediatric critical care at the University of Texas Southwestern. She earned her medical degree at the University of New Mexico in 2010, and then completed her residency in 2013 and pediatric critical care medicine fellowship in 2016, both at Duke University. Her research interest is in anticoagulation on ECMO, and her work includes investigation of heparin and antithrombin dosing while on ECMO, as well as a recent publication evaluating the effect of fresh frozen plasma on ECMO circuit life. She's currently conducting a pilot randomized control trial comparing anticoagulation with unfractionated heparin, and looking also at bivalve in pediatric ECMO patients. We are looking forward to her findings, and we're very lucky to have her talk to us today about choices of anticoagulation during ECMO.
Can you see my slides okay?
Yep.
Perfect. Thank you all for having me. I'm really excited to be able to talk to you today. Like Allison said, I'm Ali McMichael, and I'm talking to you from Dallas today. And so we're going to be talking about different choices, really only 2 choices in my mind for anticoagulation during ECMO. So I have no disclosures, although most of the stuff I'll be talking about is not FDA approved, which, to be honest, is most of the stuff that we do for pediatric patients on ECMO. So today I'd like to talk to you about bivalirudin, as I think that is the second most commonly used choice for our pediatric patients on ECMO, and its potential advantages over heparin. And then I'll review the literature, what we know now currently regarding ECMO and bivalve. And then at the end, we'll talk about what to do in the setting of antithrombin deficiency in ECMO and when and if we should be thinking about replacing. So just to start with a clinical case, just to get us thinking, you have a 6-month-old with ARDS NOS who's on day 3 of EV ECMO. And the ECMO specialist is calling you to the bedside because they've been noticing increased clot burden over the last 24 hours, really everywhere throughout the cannula, tubing, and wanted you to come take a look with your special flashlight. And so currently you're on heparin at 42 units per kilo per hour following your institution protocol. And your anti-10A is 0.2. And for this case, we'll just assume that's the main test that you're following, although Dr. Osment will talk about clinical tests.
Hey, Ali.
Yeah.
I'm sorry to interrupt you. I don't think we see your slides advancing.
Oh. You don't see any of that?
I don't see them. I don't know if anyone else is, but.
No, we just see the first slide, the choice of anticoagulation.
Is that better?
Still just the first one. Oh, there. Yep.
There? Okay.
Yep.
Okay. Thank you. So basically we have a lot of clot burden. Your heparin is high, your anti-10A is low, and then you check an antithrombin level and it's 40%. So what do you do next? There we go. Maybe you do nothing. Maybe you just keep watching and hoping everything's going to be okay. Maybe you increase the heparin based off of your protocol. Maybe you replace your antithrombin, and then the question next is, what do you replace with? or maybe even think about changing your anticoagulant to something else. So we all know this, but just to briefly review heparin, it's the most commonly used anticoagulant for pediatric ECMO. It's a complex glycogen binds to circulating proteins in the vascular endothelium. Its major mechanism of action, the one we talk about most commonly, is the binding to antithrombin to form that complex that will go on to inhibit mainly factor 2A or thrombin and 10A, but also has an effect on 9 and 12. And interestingly, that antithrombin heparin complex occurs just via a very unique pentasaccharide sequence that's really only present in about a third of our heparin molecules. There is another pathway that heparin works, and that's by stimulating tissue factor pathway inhibitor from the vascular endothelium, but we usually think about just the antithrombin heparin complex. There's a lot of advantages for heparin. I don't have to tell you guys about that, the main being that it's cheap to use. And then there is a reversal agent. So if we get ourselves in trouble, we have severe major bleeding and need to reverse heparin quickly, we can give protamine. The half-life is also advantageous. It's fast, it's available in IV form. But honestly, the biggest advantage of heparin for ECMO is that we've been using it for a long time, both in our adults and our kids and for other indications, non-ECMO related. And so we have a lot of comfort in using it. But there shouldn't be a big surprise to this audience that there's a lot of disadvantages to heparin. There's no perfect monitoring test, which Dr. Osment will talk about a lot more in the next session. And interestingly, even when we think about if there was a perfect test, it's hard to know what our target level should be. This table shows an example of the therapeutic ranges of PTT that actually correlate to what we would consider a goal 10A between 0.35 and 0.7. And you can see significant variability between a PTT for less than a 1-year-old between 82 to 177 compared to what a PTT in an adolescent or even adult would be. Fortunately, we don't see a lot of heparin or HIT in our patients, but we do see a lot of heparin resistance, which is defined as needing large amounts of heparin in order to achieve your goal anticoagulation. And then most importantly, there is significant variability in the pharmacokinetics in children. And that leads to poor maintenance of our heparin dose-dependent clearance, and a variable half-life. And we see that frequently in our neonates who often need a higher bolus dose or higher infusion doses compared to our adolescents who may need a lower dose. And then the third thing is that heparin doesn't just bind to antithrombin, it binds non-specifically to acute phase and plasma proteins, to red blood cells and platelets. This platelet activation can release heparin neutralizing proteins such as platelet factor 4 and von Willebrand factor, which can lead to more heparin resistance and need for higher doses. So why do we even care? Well, we know that the most common complications that occur during ECMO are from bleeding and clotting. And so we want to try to prevent those as much as possible. And you can argue that probably all of these complications aren't due to the anticoagulant alone, but some definitely are. And so Heidi Dalton has described significant percentage of patients who've had bleeding, up to a third of neonates and half of pediatric patients, and even a third can have thrombotic complications as well. So these are common, and we know that they're not only associated with decreased or increased morbidity, but also decreased survival as well. This is an old chart, but looking at the mechanical and patient-related complications for just respiratory patients, you can see that neonates have anywhere from 3% of infarcts to 11% of intracranial hemorrhage, and that leads to a significant decrease in survival. Surgical site bleeding, even in the non-cardiac patients, is still common, up to 7 to 10%, depending on if you're a neonate or pediatric patient. So we want to try to prevent these complications and see if there's a better anticoagulant. And so really that's where BiVal comes in. So for those of you that don't know, BiVal is a bivalent direct thrombin inhibitor. It's an analog of erudin, which is derived from the saliva of leeches. And it binds specifically to thrombin at 2 sites without a cofactor. It is reversible, unlike erudin, which is irreversible. And one of the thought to be best things about BiVal is it not only does it act on free thrombin, but it actually also acts on clot-bound thrombin. It's excreted predominantly through proteolysis, which will become a factor as we talk about BiVal more and how to use it. And 20% of the time it's cleared renally. So just to remind you, like we talked about, heparin will bind to antithrombin to form that complex and increase its activity by about 1,000-fold, whereas bivalve directly inhibits thrombin. And thrombin, as you know, is essential in the coagulation cascade because it converts fibrinogen to fibrin, it activates factor V, further promoting thrombin generation, and is a direct activator of platelets. So DTIs may actually have an indirect antiplatelet effect as well. So I already talked about a few of these things, but just to show them head to head, when we compare heparin to bivalve, you can see that the half-life for heparin is definitely variable depending on the age, but about 1 hour compared to bivalve, which is 25 minutes, so much shorter. Like I mentioned, there is an antidote for heparin, protamine, but there is none for bivalve. Heparin obviously causes hit where bivalve doesn't, and heparin, like I mentioned, I would consider to be a dirtier drug in the sense that it binds to a lot of other plasma proteins, where bivalve is much cleaner and just directly inhibits thrombin. So there's a lot of variation in heparin dose and monitoring, but most centers will use anywhere from 0.05 to 0.15 milligrams per kilo per hour. In most cases, for ECMO alone, bolus dosing is not recommended, honestly, because it doesn't produce a significant change in your PTT. Just starting the infusion is usually enough alone. Most centers will use PTT, and currently, honestly, it's the only standard lab that's used to monitor bivalve. Depending on what your center uses for heparin for your PTT goal, it's usually the same for bivalve, so either 1.5 to 2.5 times your baseline if your baseline is abnormal, or 60 to 80. There are 2 other labs that are worth mentioning that for the most part are used in research, although some clinical centers like our adult partner Clements now has dilute thrombin times. You can find some centers that will run it. The dilute thrombin time is a measurement of conversion of fibrinogen to fibrin, and it's called diluted because it's diluted to help just decrease the time for the test. It's not been FDA approved currently, but like I said, it's being used mainly for research and sometimes clinical use. The ECARE chromogenic assay is really just adds prothrombin to the initial ECT test to make the test less sensitive to coagulation factor deficiency. ECARE is derived from snake venom and is used as the specific prothrombin factor or prothrombin activator. Sorry. So ECARE will activate prothrombin into mesiothrombin, which then cleaves fibrinogen into fibrin to result in a clot formation. And then that cleavage of the chromogenic substrate in the lab by mesothrombin is inhibited in a concentration dependent fashion by TTIs, and then that will be measured optically. So to simplify this in my mind, although this is not just completely true, I think about the DTT as being more similar to a PTT and ECARE chromogenic assay being a little bit more similar to our anti-factor Xa assay. So I talked a little bit about what the advantages are for bivalve, but I think it's important to highlight the potential issues of bivalve. So like I mentioned, there's no specific antidote, although to be honest, because the half-life is so short, in most cases in the setting of significant bleed, you can just stop bivalve and it'll go away quickly. It's also really easily removed by hemodialysis, hemofiltration, and plasmapheresis. So if you needed to stop it more quickly, you can remove it that way as well. There is reduced clearance with renal impairment, so you do have to dose adjust based off of your creatinine clearance. Lab monitoring I mentioned is mainly only by PTT right now. And cost is really the big one. So the cost for heparin is significantly lower than the cost for bivalve. And so for example, cost for heparin is about 46 cents compared to about 13 per kilo per day compared to bivalve. So, more than 10 times the cost. There are concerns in the setting of low flow states. There may be increased clot burden, and that's because heparin is mainly metabolized through proteolysis. So in any area where you have low flow, you can see some increased clot burden. I'll talk to you a little bit about what we do at our center for that. There is an elevation in the INR. A recent pharmacology study found that it's probably about anywhere from 0.3 to 0.5. So that's something to know about, because if you're using INR goals in order to consider transfusion, it may change that. And then the biggest thing also is concerns for a plateau effect. And so I think if you've used bivalirudin for your VAD patients who've been on bivalve for a while, oftentimes you can see what we think about a plateau effect. So that's the idea that for increasing doses of bivalve, you're not really seeing any increase in your PTT. This should come as no surprise for you, but we don't have any FDA approval for BiVal. It's currently only approved for adult percutaneous cardiac interventions, but actually heparin isn't approved currently for ECMO for pediatric use either. So I don't think that necessarily stops us. So just to summarize things before we go on to what's known on literature and why to even think about BiVal. So I think BiVal is potentially better than heparin because there's a more predictable anticoagulant response just based off of where it acts and where it doesn't. The thought that it binds to both free and clot-bound thrombin is definitely a potential advantage. And actually in the unblocked study, which looked at pediatric patients with DVTs, they actually found that half of the patients that were treated with BiVal had actually complete or partial resolution of their clot within 48 to 72 hours, something you would never see with heparin. And then that increased to almost 90% by a month, had either complete or partial resolution of the clot. Like I mentioned, the half-life is short, so that's important to know when you're using it. One thing I didn't mention before, but hopefully was obvious from the chart, is BiVal doesn't require antithrombin in order to have its maximum effect like heparin does. So that's important for a cost. And honestly, like we'll talk about at the end, it's hard to know what to do with our low antithrombin levels. And then based off of Dr. Osmond's actually last survey, we're starting to see that more centers are becoming more comfortable with using BiVal, which means we have a lot more data to show as well. So 6% of centers that were surveyed in her study actually now use BiVal not only as a second anticoagulant, but as their primary anticoagulant. So I'm going to shift now to review what we know currently in the ECMO literature to hopefully try to convince you to think about using it in your center. So this table has just a review of going back to the last 10 years, and then I'm going to highlight 4 more recent studies. So as you can see, most of these studies are pretty small. The largest was only 72, but ranged really from mainly 10 to 20. And in the summarized findings, you can see that really there wasn't there was, if anything, showed lower bleeding in the BiVal group and potentially lower thrombosis as well. But I think it's also important to highlight that the median BiVal dose for these studies was pretty wide. And so it's something that we're still trying to work on is what should be the best dose for our ECMO patients. And it's also important to know that all of these studies, except for the last study by Ryerson and all, were retrospective. But the first study that I think is just important to highlight historically is the Vernucci study. This was published in 2011 and at least got my center excited to think about using BiVal. This was a retrospective single center study of post-cardiotomy VA pediatric and adult patients. And the center actually switched to BiVal as their primary anticoagulant after they had 2 cases of HIT. So you can see here their time on ECMO for their BiVal group was actually longer than their time on heparin. But what was really exciting is when they looked at bleeding. So when they looked at total bleeding for mLs per kilo per day, you can see the heparin group is that first column. They had about 51 mLs per kilo per day of bleeding compared to their BiVal group of only 16. And then when they looked at transfusions, except for PEC red blood cells, they saw a statistically significant decrease in transfusion in FFP, platelets, and antithrombin in their BiVal group compared to their heparin group. RBCs looked like there was a trend to lower, but it wasn't statistically significant. And then what I think was really interesting in this study and also got people excited was looking at costs. So this was a European study, so they looked at cost in euros, but you can see the cost for adults had a trend less for BiVal, but wasn't statistically significant, but the cost for children was. And so to look at cost, they looked at not only the cost of heparin and BiVal, but they also looked at the cost of transfusions. And so since they had significantly less transfusions in the BiVal group, the cost was lower. And I think that's important for 2 reasons. One, obviously, we want to make sure we're not charging our patients more. ECMO alone is expensive enough. But also we know that besides transfusions being costly, they come with significant morbidity and possibly mortality as well. So we'll transition to 2 pediatric more recent studies just to highlight because they came out within the last 2 years in case you haven't seen them. So this was a retrospective cohort study done in Florida of 32 consecutive cardiac VA pediatric patients. Their centers shifted completely over to BiVal. So they did historical 11 heparin patients and then 9 BiVal patients after that. Or sorry, 14 and 18. This table is showing you the blood product utilization for patients less than 1 year, and then they separate it to greater than 1 year as well. As you can see, there wasn't any statistically significant difference between the two groups, both in the less than 1 year and in their greater than 1 year. The red blood cells were correlated with a higher blood loss in the heparin group with a Pearson correlation coefficient of 0.49. And the other thing that was interesting in the study they looked at was something called iatrogenic blood loss. So they looked at the blood loss from lab testing in the group and found that the heparin group had a blood loss of 1 ml per hour compared to the bivalve group of 0.5 mLs per hour with a p-value of 0.003. So that does sound really exciting to think about. You know, there's a nice trend in decreased blood products and then potentially less blood loss. But I think the important thing to note for this study is that they did ACTs every hour in their heparin group. And then they looked at 10As every 6 hours, whereas in the bivalve group, they didn't follow ACTs and they followed PTTs. So they were following PDTs every 2 hour with a dose change and then every 6, but again, that's not an every hour testing. And so it's hard to really tell if part of that blood loss was really from the protocol and not necessarily from heparin being less reliable and needing more changes in their dosing, if that makes sense. So I think this study is exciting that there's a little bit of at least interest in less blood loss, but I don't think this is a study that necessarily gives us a lot to go off of to change our mind. This study also came out in 2020 in critical care. This was a retrospective review of 32 pediatric VV and VA. These are PICU patients, so non-cardiac patients. This is at Cleveland Clinic. They changed also to bivalve as their primary anticoagulant, so looked retrospectively. In their study, they found equivalent thrombotic events between the two groups, although when you actually looked at the numbers, 9% of the patients in the heparin group had a thrombotic event and none in the bivalve group, but it just wasn't statistically significant. They had decreased bleeding events in their bivalve group and actually decreased time to goal anticoagulation. They also looked at costs like the Renici study and found the cost was lower in the bivalve group as well, which was good to see. One thing I think is nice to highlight in this study is this is our figure 2. So you can see in the, figure A, this is our bivalve dose over day 1 to day 5. So they did have to increase their bivalve pretty consistently over those 5 days. But when you look at figure B, you were able to see they were within target range for pretty much the entire first 5 days. And actually their 12-hour bivalve mean dose was already within range, which is really interesting to see. What I think is the most interesting thing about this study though is actually figure 3. So this is looking at platelet counts compared to the two groups, bivalve in figure A and heparin in figure B. And so you can see their platelet count between the two groups started out about at 100 for both of them. And then the bivalve group dropped a little bit for the first 2, maybe 3 days, and then rose back up to where they were. Whereas heparin steadily decreased their the heparin group, steadily decreased their platelet count over the 5 days. And so I think this is an interesting finding, and you could theorize maybe this is due to the fact that that heparin activates platelets and there may be more platelet consumption, whereas bivalve hopefully doesn't. But I think also goes along with the fact that we're seeing less transfusion need for our bivalve group compared to our heparin group, and that can be significant, especially in our neonatal population, who we often drive higher platelet counts. There can be a significant less amount of transfusions if you're able to keep your platelet count greater than 100. Transitioning to 2 adult studies I wanted to highlight. These are just because these are higher numbers and came out within the last 2 years as well. So this was a retrospective review of 52 adult VV and VA patients. They transitioned their patients to bivalve only if they had heparin resistance or HIT. So this was not a transition of anticoagulant per the center. And they looked at a few different things for the study. So first was the percentage of time that they were within the therapeutic range of PTT. And that's the black box that you see comparing heparin to bivalve. And you can see there was a difference between the two groups. 86% of patients spent most of their time within the therapeutic range compared to only 50% in the heparin group. The darker gray is a composite thrombotic event. And so they looked at a 7-day rate of VTE, arterial thrombotic event, and ECMO in-circuit clot, clot in the ECMO circuit that was either in the cannula or the oxygenator. So they didn't care about the tubing itself, just the cannula or the oxygenator within those first 7 days. And so they found that while there was a trend for bivalve having less thrombotic events, that was not statistically significant. And then the lightest gray is major bleeding event. Again, there was less in the bivalve group, but not statistically significant. But really what's interesting from this study as well is the same thing with platelets that I just showed you from the pediatric study. So the platelet count is the top graph, and you can see darker black and heparin is in gray. And over the 168 hours, you can see that bivalve group, their platelet count actually rose a little bit over the time, whereas the heparin group steadily decreased over that time as well. And then the second graph that you can see is the PTT. So you can see a really steady PTT for their bivalve patients, whereas the heparin group was kind of all over the place. Again, I think what we see in real life as well, that bivalve seems to be a lot steady, more steady when it's on, but exciting to see those trends for platelets. And then the last study that I wanted to highlight was a study which prior to today was the largest study of bivalve patients that has been published. So this was a retrospective cohort of almost 300 patients. They looked from 2013 to 2020, so went back several years, but there's 162 heparin patients and 133 bivalves, so good to see that many numbers. They had two primary outcomes. The first was in-circuit thrombosis, and so they defined that as any clot on any part of the ECMO circuit that led to either a part of the circuit being changed, so whether that's the oxygenator or entire circuit change. And they actually analyzed that in 3 ways: whether or not that occurred, so the development of that, how long it took, time to initial, and then thrombosis per ECMO day. And then they looked at total blood product transfused. So you can see this is their table 2 here. So they did see a difference between the two groups. The bivalve group had significantly less in-circuit thrombosis compared to the heparin group. And when they standardized that per ECMO day, it still was significant. And then here's their transfusions. You can see a significant difference both in red blood cells, FFP, and platelets between the two groups. This is just the total mean, but when they looked at per ECMO day as well, it was also significant. What's also not shown here is there was also a significant decrease in the number of major bleeding events. So only 11% of the bivalve patients had a major bleeding event versus 40% of their heparin patients. But I think what's probably the most obvious that you've seen through these studies is that none of these are randomized control trial. All of these are retrospective studies. Currently at my center, we have a pilot study that we are almost done enrolling, although I haven't said that for the last year. Thank you, COVID. But there are no RCTs. There were 2 RCTs in clin trials for the adults, and so but I just actually checked yesterday, and one has stopped because they were unable to get funding, and one is not recruiting. And so unfortunately, I think ours is the only one right now. There's a lot of issues in these studies because they're comparing to historical data. So most of the studies I showed you were centers that had switched from bivalve to being their primary anticoagulant and were comparing to historical controls. And I think that's partly a problem, as you know, that we've had a lot of changes in the last 5 to 10 years, both in the circuits. A lot of us have changed over to cardio help, which may change the amount of hemolysis that we have. And then a lot of us have different protocols, or at least hopefully improvement in our protocols and how we're managing these patients over the last 5 to 10 years. I didn't highlight this specifically, but a lot of the studies had different definitions of bleeding and thrombosis, and we see that a lot in the ECMO literature. Some use ELSO definitions for major bleeding, some use their own definitions. Thrombosis is always a difficult one to define, so some use clot in the circuit, some use a circuit change, but even that can be really subjective. So it's really hard to be comparing apples to apples in these studies. And then the other thing is a lot of these studies use different dosing and monitoring strategies. So the last adult study that I showed you, they used, or a lot of the studies use 10A for monitoring heparin, while they use PTT to monitor bivalve. And so are you really looking at the same test? And Dr. Osment will talk a lot more about that. But I think when we think about these studies, it's difficult to really be comparing when we're looking at different monitoring strategies. It's difficult to know, was bivalve really better because the anticoagulant is better, or was just the monitoring strategy they chose better? That's really what we know so far. I will tell you what we're doing currently at Children's as part of the trial is that we give a heparin bolus at time of cannulation, and then if the patients consent to the study and they get randomized to bivalve, we start at 0.15 and we titrate every 2 hours with a dose change until we get to steady state, and then we monitor every 2. And we've found really good success with that. And so before we move on to antithrombin, I just wanted to pause and do just a kind of quick my thoughts of using bivalve. And I'm happy to talk to anyone afterwards, and feel free to email me if you have questions, because I think that we're all learning a little bit how to use bivalve the best way. So I have seen a lot in the literature, and a lot of people talk about the plateau effect for bivalve. So again, that thought of as you're increasing your bivalve dose, you're really seeing no difference in your PTT. We haven't really seen that at our center, at least in our patients. We see it more in our bad patients. We have we're lucky in that we can send for a DTT at our adult center across the way. So I think if that happens to you, that's always nice to just check to see what the dilute thrombin time is. Seattle can also run bivalve assays. They've done that for us in the past as well. But I would say we've only seen that in one patient who was on bivalve for more than a month, and we checked a DTT and she was within range and had no bleeding and no clotting. And so we felt comfortable with our PTTs being a little bit low. I think the major thing that we have found is what to do with low flow states. So for us, we know that we're going to get clots in the pigtails that we're drawing labs from. We have to change out the stopcocks frequently. And so our ECMO specialists know that, and they flush them very well before drawing the labs. And then that hasn't been a problem. What we have found that can be a problem is the reperfusion cannula. So if we have patients who are femorally cannulated with a reperfusion cannula that has a lower flow, we have found that we can have increased clot burden and actually clotted off a cannula before. So we run a low dose bivalve through that cannula, anywhere from 0.05 to 0.07, and we haven't had any issues after that. I will tell you, because I don't think anyone from our CVICU is on, but our CVICU and our PICU do clamp trials very differently. So our CVICU sometimes will do clamp trials for over an hour, and they may do that several times. And we have noticed that we can have some clotting in our cannula for these prolonged clamp trials. So in order to mitigate that, we give a bolus of heparin. And I think we stole that from another center, and we haven't honestly had any issues with that either. We do check echoes on our patients to look for the concern for intracardiac thrombus. So that's also been documented in the literature, concern for an intracardiac thrombus in the setting of severe LV dysfunction. We haven't seen that, but I think that's important to know about and continue looking. If you have a patient in a CVICU or in the PICU with sepsis on bivalve, to make sure that you are echoing frequently to look for clot. So that's really what I have for bivalve right now. Like I said, we'll take questions at the end, but I want to transition to talk a little bit about antithrombin. So we're going back to our case, and we still have this clot burden, and maybe you decided you wanted to switch over to bivalve, but unfortunately you don't have it at your center. So the next question is, what should you do? Should you give antithrombin? So what is antithrombin? I think you all know this. So just to go over briefly, it's an endogenous alpha-2 glycoprotein. It irreversibly inhibits thrombin and 10A. So like I mentioned before, again, heparin will bind to antithrombin and potentiate the inhibition of thrombin by 1 to 2,000 fold. So it's definitely necessary. But we know in our ECMO patients, for lots of different reasons, that antithrombin is decreased. And to that, infants don't achieve normal antithrombin levels until about 7 to 12 months of age. So We know that more centers are monitoring antithrombin, and that actually comes from Dr. Osmond's recent survey. So more than 90% of centers either routinely or occasionally are monitoring antithrombin, and about half of our centers are replacing antithrombin. There's currently 2 forms available in the US, the pooled human and then the recombinant, which comes from milk of genetically engineered goats, which I learned for this talk. The recombinant form, I believe, is still available in the US, although it got bought out by a different company. But most of us are more familiar with the pooled human thrombate 3 form from Grifols. So when should we administer antithrombin? And so ELSA recommends giving antithrombin if you're on a maximum dose of heparin and you're unable to obtain your anticoagulation goals. But the problem is we actually don't have any defined or validated goal of what our antithrombin should be when we're fully heparinized on ECMO. We don't know if it should be 20 or 40 or 60 or 100. And it's also really hard to know what maximum heparin means as well. So most centers have a definition as well, anywhere between 40 to 60 units per kilo per hour, what they would consider maximum. And we don't have time in this talk to review all of the studies looking at antithrombin, but I will tell you that the current pediatric and adult retrospective studies all have highly variable protocols and highly variable results. Some showing concerns for bleeding, some showing concerns for clotting, but most are showing there wasn't significant benefit. I'll actually send you to this reference by Megan Chabowski and Phil Spinella, which actually, if you go to their additional file 1, summarizes all of the antithrombin studies in ECMO patients, and is a really nice resource. But I did want to highlight one study because it was a very highly anticipated randomized control trial for antithrombin. So this came out in 2020 from 2 centers, adult centers in Milan. They randomized 48 patients to either control, so that was following their heparin protocol, versus antithrombin replacement, and they replaced them to a goal of 80 to 120. Their primary outcome was total amount of heparin required to see a PTT between 1.5 to 2.5 times their baseline. And so what they were hypothesizing was that giving antithrombin would decrease the amount of heparin that you would need to give to the patients. But unfortunately, this highly anticipated study ended up being a negative study. So antithrombin did not decrease the heparin dose in their patients, and they saw no difference in bleeding, transfusion need, or thrombosis. When they did a post hoc analysis, they were able to see decreased heparin dose in those patients who had an antithrombin level less than 60. So this, the authors concluded that potentially antithrombin may be beneficial when your AT level is less than 60%. I think part of the biggest problem for this study is when you look at your table 3, this was the median antithrombin during the study for their patients. So the control group actually had a median antithrombin level of 84%. So really, I think, one, that's not what we normally see in our pediatric patients, especially in our neonates, but also lends to why they likely didn't see a difference in the study. So if you were going to dose antithrombin, here's the dosing that most people recommend. I actually stole this from Phil's paper. But I think in general, we know that while we're monitoring antithrombin, we really don't have great data about when or if we should give it. I think the last retrospective study from Milan potentially, based off the post hoc analysis, you would say less than 60% seems reasonable, but we really need a pediatric perspective trial to look at this. And I think the biggest thing for that trial would be defining the level at which we would transfuse. And so transfusing, picking a number, thinking about less than 40, less than 60, or less than 80. So we need several arms so we can actually see a difference between the groups. So in summary, hopefully I've given you some things to think about that you may do differently for this patient. Some of you may still decide that you want to keep going up on your heparin for the clot burden that you're seeing so far. Some of you may still just do nothing. Some may decide to give antithrombin if it's 40%, but what would you do if it was 60 or 80%? And hopefully I've convinced some of you to at least think about using bivalve as another potential anticoagulant for our pediatric patients on ECMO, knowing that we definitely still need more studies, and hopefully we'll continue to get those over the next couple of years. So with that, thank you so much for joining me virtually for the talk, and I'll be happy to take any questions at the end.
Excellent. Thank you so much, Dr. McMichael. All right. So next up, we have Dr. Carolyn Osmond. So Dr. Osmond is an assistant professor in pediatrics at Duke University. She earned her medical degree at the University of South Alabama in 2003, followed by a pediatric residency at Oregon Health and Science University in 2006 and pediatric critical care medicine fellowship at Duke University in 2009. She's currently the director of pediatric ECMO at Duke Children's Hospital. And her research focus includes anticoagulation management and monitoring in ECMO, including collaboration with and mentorship of our previous speaker, as I think you've heard. She's also interested in anticoagulation in ventricular assist devices and post-liver transplant patients. She's an expert in transfusion medicine and interested in the effects of blood storage on patient morbidity and mortality. And we're just very happy to have her and honored for her to bring all of this expertise to her talk today, which will focus on approaches to anticoagulation testing and monitoring during ECMO.
Hi, everybody. Thanks for the introduction. Can you guys can see my slides? Great.
Yes.
All right. So as Allison mentioned, I'm here to talk to you today about approaches to anticoagulation testing and monitoring during ECMO. I love that Allie spent so much time on the bivalve in her previous talk because I felt like I ran out of time to talk about bivalve. So I'm glad that she had that in hers. Let's see, mine is not advancing. There we go. Okay. I have no disclosures. And I thought we would start out looking at what our current anticoagulation practices are. As Allie mentioned, we recently published a survey on anticoagulation and transfusion management as a follow-up survey done by Mela Bembea in 2013. In the most recent survey, 99% of centers used an anticoagulation protocol, and only 13% used a single assay to monitor their anticoagulation. Those who used more than one assay most commonly used anti-factor 10A and ACT. And you can see here on the right the differences in the individual assay use between 2013 and 2021. One thing we found interesting was the decrease in ACT and PTT usage from 97 and 94 to 75 and 62% respectively. And then the huge increase in regular anti-factor 10A use from 60 to 90%. And then finally, overwhelmingly, heparin still remains the anticoagulant of choice in pediatric and neonatal ECMO. And because of this, and because of the limited time that we have today, I focused my discussion with you on heparin monitoring. And so there are a couple things I want to go over before we talk about the individual assays. We'll do a quick drive-by discussion on hemostasis because I feel like no anticoagulation monitoring discussion is complete without that. We'll define some variables that may impact our results, and then we'll discuss the difference between optical and electromechanical assays. And I want to point out before we get started that there are established ranges for pediatric norms in most of the assays that we'll discuss today, but there are no proven superior treatment ranges for any of these assays in the pediatric ECMO population. And so this is really where a lot of research still needs to be done. All right, so as I mentioned, every talk on anticoagulation deserves this little slide in here. On the left is the cascade model that most of us were taught in medical school if we stayed awake long enough. And on the left side of this figure, we have the intrinsic pathway, also known as the contact factor pathway. And on the right, we have the extrinsic or tissue factor mediated pathway. And these two paths converge in the common pathway at factor 10 and go on to ultimately form a clot after forming fibrin. And the paths have historically been considered redundant and were thought to occur independently while the factors were just kind of floating around in the blood. And over the past 20 years or so, it's become apparent that the in vivo hemostatic process is much more complex, with overlapping stages and crucial steps occurring on the cell surfaces of endothelial cells and platelets especially. And on the right is the more recent model for hemostasis, which includes an initiation, propagation, and amplification phase. And this is the cell-based model of hemostasis. several of them, the assays that have been used to monitor anticoagulation therapy over the years, like the PTT, ACT, and PT, were developed in the in vitro to measure the in vitro activation of the discrete pathways in the cascade model, while removing the contribution from the other variables. And because we're still using these assays regularly today, I think it's important to just kind of remember the cascade model in order to understand the assays, while still understanding the cell-based model of hemostasis as the in vivo reality. And while considering heparin effect, we'll be looking at the impact of the heparin antithrombin complex on factor 10A and 2A mainly. And most of these assays will use a factor 12 activator like kaolin, C-Lite, or glass beads. So I think it's also important to talk about variables that can impact laboratory assays, laboratory results that we get. Pre-analytical variables or anything that will happen to the sample prior to analysis in the lab that may impact the results of the assay in a way that's separate from the intended measurement. Analytical variables are those factors that may influence the result during sample processing. And post-analytical variables are things that lead to delayed or inaccurate reporting. And the analytical and post-analytical variables are things that we as clinicians can't do a whole lot about, but they're still important to be aware of. But then finally, there's this extra category of post-analytic variables, which includes, as clinicians, our knowledge regarding the assays we order and our informed interpretation of the results. And it's this category that I'm hoping to influence today with my discussion with you. And then one other thing to talk about before we talk about the assays is the difference between optical and electromechanical assays, because understanding the difference between the two is important when you're making decisions on the ACT, PTT, and PT that you order on your patient. In the mechanical clot detection method, clot formation is detected using a change in movement of a metal ball between two magnets, or the change in movement between two probes to a finite endpoint that's recorded as a clotting time. And the second method is the optical method, shown to the right, which detects clot formation using the change in turbidity of the sample. And so the results in assays using the optical method may be influenced by anything that impacts turbidity, including high levels of bilirubin, plasma-free hemoglobin, triglycerides, and all of which are not uncommon in our ECMO patients, and an example of a pre-analytical variable that impacts our results. And then in addition to this, I want to point out that because of the way that these assays measure clot, the time to clot is really stopped at the very beginning of the actual clot. So it really doesn't give you an overall view of the entire clot formation. And we'll talk a little bit more about that. All right, so let's just do a brief overview of each of the assays. So looking at the ACT, our early anticoagulation practices for ECMO evolved from cardiopulmonary bypass, and the ACT has long been used as a point of care test to monitor heparin therapy in the OR. In this assay, a factor 12 activator is added to a whole blood sample, and the time to clot is measured in seconds. It's important to note that the ACT can be prolonged by things other than heparin effect, and some of these things are important in ECMO patients and include deficits in factor deficiencies, thrombocytopenia, hypothermia, and hemodilution. So if your patient is cold, hemodiluted, or in DIC, this will be reflected in the ACT and is something you probably want to know. But if the tube is contaminated with saline, diluting the factors, or the processing is delayed, or there's excessive hemolysis and you're using an optical analyzer, then the results will be inaccurate. So for each of these tests, I am hoping to just kind of compare the pros and cons, and I put it in table form to hopefully help us get through them a little bit easier. So for the ACT, the biggest pro is that it's fast, cheap, and readily available in any center that does ECMO because it's still routinely used in cardiopulmonary bypass. I think we can also consider the fact that the ACT is sensitive to things like thrombocytopenia and factor deficiency, a pro instead of a con, since ongoing platelet and factor consumption is a very real problem in the ECMO population. But it does also mean that we can't rely on the ACT to inform us only of effective heparin dose. In addition, ACT has been shown to be a less sensitive assay at lower heparin doses used in ECMO than compared to cardiopulmonary bypass, and the clotting times are actually dependent on the activator that's used in the assay. But the biggest problem, in my opinion, with the ACT is its poor precision. In fact, a recent study done by Wayne Chandler's group in Seattle found that ACT values outside the therapeutic range are more likely to be due to random error than actual change in heparin activity. And so because of this, the ACT seems to be the most inferior of the heparin monitoring assays, although it remains the most widely available and it's still commonly used. So I think it's important to discuss it. Moving on to the PTT, which is a measure of time to fibrin clot for the contact factor pathway. And I say it's a measure of the time to fibrin clot because it's performed on platelet poor plasma. And in this assay, just like the ACT, we have a factor 12 activator that's added to the sample along with calcium to reverse the citrate and some phospholipid to act like the platelet surface, and then the time to clot is measured. The partial in the name refers to the addition of phospholipid, but not tissue factor. The thromboplastin added to the clotting assays was originally derived from placental sources and was later found to include both tissue factor and phospholipid. It's added to the prothrombin in time, which is measuring the tissue factor pathway, but not added to the PTT. And PTT reagents can vary significantly. So the American College of Chest Physicians and the American College of, the College of American Pathologists have made the recommendation that therapeutic ranges at each institution should be correlated to the anti-factor 10A or protamine titration level that's considered therapeutic at that institution. So if we look at the pros and cons, go back there. So if we look at the pros and cons of the PTT assay, you can see that like the ACT, it's readily available. It's more sensitive than the ACT at the lower heparin doses used in ECMO. It does also remove the contribution of platelets to the clotting process, but is still sensitive to both the heparin effect and factor deficiency. So it's not going to be a pure measure of effective heparin dose. It's usually a lab test, although there are point of care assays available, but the turnaround time's a little bit longer. It's impacted by lupus anticoagulants, and the optical method will be impacted by substances that impact turbidity. And then finally, as I mentioned earlier, the reagents vary significantly. So if your center sets the therapeutic range based on the assay control instead of on anti-factor 10A or protamine titration levels, that could be an issue as well. So looking at the anti-factor 10A level, which has been gaining popularity in the ECMO population, ECMO community recently, I want to spend a little bit more time on this assay because I think it's super important that clinicians understand what this assay actually does. I like to think of it as a level of effective heparin, and heparin vials contain a heterogeneous mixture of different size molecules, and only certain sizes exert the anticoagulant effect. A known amount of exogenous factor 10A is added to a sample of your patient's plasma in this assay. And during normal circumstances, we have negligible amounts of circulating factor 10A since it's bound by antithrombin and removed from circulation. The heparin antithrombin complexes in the serum bind to the exogenous antithrombin that you add to the assay. Bind to the exogenous factor 10A that you add to the assay. And since that exogenous 10A is added in large quantity to ensure that all the heparin antithrombin complexes are bound, there will be some leftover exogenous 10A. And then this leftover exogenous 10A cleaves a chromogenic substrate added to the assay, which results in color development of the sample that can be measured and is inversely related to the amount of heparin antithrombin in the sample. And I know that there are several of my prior fellows on this call, and I guarantee they're all rolling their eyes because they've heard me talk about this 8 billion times. So the important thing to note about this assay is that it doesn't tell you anything about the hemostatic status of your patient, with one very small exception in some cases. There are some anti-10A assays that call for added exogenous antithrombin, making these assays a pure measure of effective heparin level or dose. But the most commonly used assays don't add exogenous antithrombin, which means that the assay is also a measure of effective heparin antithrombin dose, and that any significant antithrombin deficiency will also lead to a low anti-factor 10A level, regardless of the heparin dose. The other thing to note is that with some anti-factor Xa assays, dextran sulfate is added to minimize the binding of heparin to heparin binding proteins other than antithrombin in order to assess the true anticoagulant potential of the heparin dose. And the problem with this is that it may overestimate the in vivo anticoagulation status, since some level of heparin binding proteins are likely to be present in your patient. And so having dextran sulfate in the assay is really only useful if you're trying to determine whether excess binding proteins are contributing to an unexpectedly low anti-10A level. So let's look at the pros and cons of the anti-factor 10A assay. It's a good measure, a great measure of heparin, effective heparin dose. And you'll see here that that's the only pro that I have listed for the anti-10A assay. And I don't want to undersell the value of this point. It's a positive thing to be able to measure the effective dose of heparin. But I think we can all agree that our ECMO patients have some degree of underlying coagulopathy, either from ongoing factor and platelet consumption or from the underlying disease process. So I would argue that measuring the effective heparin level in these patients is not enough, since it's quite possible to have a therapeutic anti-factor 10A level and a significant clinical coagulopathy at the same time. This is something that I think is important to know while treating these patients. The anti-factor 10A assay also is a lab test, so it's a longer turnaround time than a point of care test. It may not be as readily available as the ACT and PTT, and it's a chromogenic assay that may also be impacted by severe hemolysis or hyperbilirubinemia. And as I mentioned earlier, the presence of dextran sulfate may lead to overestimation of the heparin effect. All right, so hopefully you guys are all still awake after that rapid fire through the assays. Let's move on to the final test that we'll talk about today, and that's the viscoelastic assays, which come in two flavors, TEG and ROTEM. TEG stands for thromboelastography, and ROTEM stands for rotational thromboelastometry. And these assays can be very useful as they provide a graphic representation of the entire clot process. In both assays, a pin is suspended in whole blood in a cup. Traditionally, the difference between the assays are what rotates and the clot detection method. In the traditional TEG, the cup oscillates, and in the ROTEM, the pin oscillates. And as the blood clots in the cup, resistance to oscillation occurs, and this change in resistance is measured and plotted in graphical form over time, giving us a view of the entire clot process and not just the beginning like the ACT and the PTT. In the newest TEG system, the TEG 6S actually uses resonant frequency analysis, where the sample is exposed to a number of different frequencies, and as the clot forms, the frequency that causes the most jiggle within the sample will change, and this change is detected and plotted into the TEG curve that we're familiar with. And so the curve produced by these two assays has a wealth of information for clinicians. So here's the TEG graph. And if you look here on the far left, you'll see the R time, and that's essentially the coagulation process all the way up to the beginning of fibrin formation, and factor deficiencies and heparin effect will be seen here. And then after this point, as the curve starts to form, is where fibrinogen continues to be converted to fibrin, and clot formation begins, and the curve moves away from baseline. And so the point from 2 to 20 millimeters above baseline is known as the K time. You can see that on the bottom. And the alpha angle is the slope between the K and the R times. And so the alpha angle and the K time are both representative of the rapidity of fibrin formation. And the maximum amplitude is the highest vertical point of the curve and is representative of clot strength. So a wider curve is going to represent a stronger clot. Quantitative and qualitative deficits in platelets and fibrinogen will manifest with a lower maximum amplitude in the curve portion of this graph. And so then we have the lysis at 30 minutes, which is the percentage of decline from the maximum amplitude after 30 minutes, and provides information on fibrinolysis. TEG testing comes with several options to help us differentiate problems with hemostasis. The kaolin tag uses kaolin as the factor 12 activator to assess the time to clot via the intrinsic pathway in unheparinized patients. But in the heparinized patients, the kaolin tag gives you information on your heparin effect. The kaolin tag with heparinase uses heparinase, which is an enzyme that breaks down heparin and reverses the heparin effect. So you're left with the patient's intrinsic cascade and can assess for factor deficiency. The rapid tag combines tissue factor and kaolin, so you're actually visualizing both the intrinsic and extrinsic cascade, which results in a much faster curve forming. So it's about 10 minutes as opposed to about 45 minutes since you're activating the entire hemostatic system. And this is really useful in massive hemorrhage situations like in OB and trauma and that kind of thing, because it can cut down the time significantly and allow for providers to rapidly tailor their transfusion therapy. The tag functional fibrinogen adds a platelet inhibitor to remove the platelet effect from the maximum amplitude and assess the fibrinogen contribution to the clot strength. So if the MA is low on your tag functional fibrinogen, then your fibrinogen is likely low. If the MA is normal, but low in a kaolin tag or a kaolin tag with heparinase, if your patient is heparinized, then you probably have a quantitative or a qualitative platelet deficit. And then finally, the tag assay also has a platelet mapping function that can define qualitative platelet deficits. The ROTEM assay produces a similar graph, although the terms are labeled a little bit differently. The ROTEM actually has an NTIM and an XTIM. The NTIM is activated with a factor 12 activator and the XTIM with a tissue factor. And then the FIB-TIM is the same as the tag functional fibrinogen. And the HEP-TIM is the same with the kaolin tag with heparinase. And the parameters that you're looking at are labeled a little bit differently. So for instance, the R time is a clotting time in the ROTEM, and it's maximum clot firmness instead of maximum amplitude, but the theory is the same between the two. And I think it seems that TEG seems to be more commonly used than ROTEM. We are a ROTEM center at Duke, but I think TEG is the most commonly used. So if we look at the pros and cons of viscoelastic assays, one of the biggest pros, in my opinion, is that these assays give you a whole clot representation, which I think is just so useful in our ECMO patients. The heparinase option is convenient because it allows for the differentiation between heparin effect and underlying coagulopathy, and then further having being able to assess the difference or the contribution of thrombocytopenia or platelet or qualitative platelet dysfunction is also very convenient. The cons include provider unfamiliarity. There's little data in the pediatric population and even less in the pediatric ECMO population. It's not available at all centers. And at high levels of lupus anticoagulants, the viscoelastic assays may be impacted as well. And so a couple of other miscellaneous things that I just wanted to quickly go through. All of our assays will be impacted by sample integrity. So just making sure that you don't have excess heparin contamination or saline contamination is important, as well as having inadequate sampling in citrate tubes. And then another consideration is that the PT, I discussed the ACT and the PTT helping us measure factor deficiency in our ECMO patients. The PT and INR is also a very convenient assay that can be used to assess factor consumption without confusing the provider with the heparin effect. And it may be a cleaner measurement of factor deficiency in patients without liver dysfunction. And in those three graphs on the bottom right, that's the study I referenced earlier from Wayne Chandler's group, and it gives you, it shows you the correlation to PT, PTT, and ACT as factor levels were decreased in a sample of blood at the same level of heparin. And you can see that the PT-INR has the highest correlation of all. And so using a PT-INR combined with the anti-factor 10A level is not an unreasonable approach to looking at both heparin effect and factor deficiency. And then measuring your antithrombin activity level, if that's something that your center does, may be useful when heparin resistance is suspected. But as Ali pointed out, the data for supplementation is pretty unclear. And so it's tough to know what to do with the antithrombin levels that we get. Making sure that you look at fibrinogen level in your ECMO patient, that is important as well, since isolated low fibrinogen is going to impact both your PT and your PTT. And then remembering that our patients on ECMO are prone to having von Willebrand factor deficiency, which may also prolong the PTT. Again, kind of like the antithrombin level, it's kind of tough to know what to do with those levels if you get them, but it may help you understand what's going on with the labs. So now, after discussing each of the individual assays, we have to decide which assays to use or which combination of assays to use on our ECMO patients. And this comes from the 2014 anticoagulation guidelines that ELSA put out, where they state that using one method of monitoring heparin activity only is likely no longer acceptable in ECLS practice, but using multiple tests of heparin therapy multiple times a day is probably not necessary and will be very confusing for the ECLS team members. Ultimately, every program has to come up with an approach that works best for their patients in their individual center. So let's talk a little bit more about that. So what does the data show about which assay to use and how many assays? There are conflicting data on whether a simple versus a more complex monitoring strategy is superior. And no single assay has been shown to reliably predict outcomes. And this is likely due to the diversity in the patient population, as well as the wide variability in the ECMO circuit setups. Many of the studies examining assays for ECMO anticoagulation use the correlation to heparin dose as the outcome of interest, which I would argue is probably not the best outcome of interest, knowing about the factor consumption and inflammation that our patients have. I think it's more complex than that. But I think there are a few things that we can say. I think that we can say that that the correlation between the different monitoring assays is unreliable, and there are a number of rational reasons for this, as we've already discussed. So it's really not that unanticipated. I think we can say that ACT is likely the inferior time to clot assay. And then finally, I think that we can say that single assay monitoring with anti-factor Xa will miss underlying coagulopathies. So disappointingly, I can't tell you exactly what assays to monitor. I can tell you what we do and what sounds reasonable to me. At Duke, we ascribe to the multi-assay individualized approach to monitoring ECMO anticoagulation. And this is our basic approach, but it could be modified depending on some of the available assays at your center. We use a time to clot assay, and for us, that's the PTT, and we use an anti-factor Xa level and fibrinogen level, and then we measure the interfering substances that we think are common in our ECMO patients, and then we get a platelet count. And we get a PTT every 6 hours, and then all the rest of that stuff on that top line just once a day. And then we examine the patient characteristics like inflammation, liver dysfunction, postoperative state, developmental hemostatic differences, and the state of the circuit, and make changes around the heparin dose based on that. And for us, with TEG and ROTEM, we tend to use those as ancillary studies to confirm, once we've gotten a bigger picture from all the assays listed there and looked at the patient. If there's still some confusion, we'll go ahead and use viscoelastic testing to help further clarify that. So I wanted to kind of go over a couple of cases with you guys and just kind of get a pulse on what other people do in these scenarios. And we can definitely talk about them in the comments portion at the end of this webinar. So the first case is a 7-day-old 2.7 baby on VA ECMO for meconium aspiration syndrome. The baby's receiving 20 units per kilo per hour of heparin, and on clinical exam has oozing from puncture sites and mild hematuria. In the circuit, you see scattered fibrin deposition in the venous limb. The PTT is 105. The anti-factor Xa level is 0.25. Fibrinogen is 105, and your antithrombin level is 30. So we have, everybody wants to weigh in what you would want to do in this clinical scenario. Hopefully it's working. I don't see any. All right, we may not be working. Well, we can discuss each of these. Oh, wait, never mind. I like it, it's changing. And I should say there's not necessarily a right answer to this situation. I'm gonna give it a second after the last one. All right. So we've got a pretty equal split between decrease the heparin, give some FFP, give some antithrombin, and then a couple do nothings. So this is not an uncommon scenario for us, especially in the babies. So let's look at some of the potential etiologies for this situation. First of all, our anti-10A level may be low because of insufficient antithrombin if our assay does not contain exogenous antithrombin. It could also be low because we don't have enough heparin. It could be low because we have an interfering substance in a chromogenic assay like hyperbilirubinemia or plasma-free hemoglobin. It could be sample integrity with saline contamination or delay in processing. But it could be that our PTT is just high. And thinking about why the PTT could be high, this may be developmental differences in hemostasis. It may be a higher factor 2A heparin effect, which has been shown to be developmentally related as well. We could have decreased factor levels, some degree of consumption. There could be a lupus anticoagulant. And then again, in this scenario, there could be some problem with sample integrity, including saline contamination or an underfilled sample tube. So there are a number of things that could be contributing to the clinical situation. And, I think, like I mentioned earlier, just looking at the patient and thinking about the clinical scenario, this patient had some evidence of both bleeding and clotting. I think at our center, we probably would go ahead and get an INR and potentially supplement with some FFP, knowing that the patient was having issues with both bleeding and clotting. So for our next patient, we have a 5-year-old on VA ECMO for cardiac shock secondary to myocarditis, and the circuit exam is significant for high clot burden. Our PTT is 41, anti-factor 10A level is 0.6, fibrinogen is 750, and platelet count is 527. And here are the options for what you could do with this patient. I feel like Phil might be voting multiple times on this one with 88%. Still voting. All right, looks like we've slowed down a little bit. So most people would say order a kaolin tag with and without heparinase, and I would do the same thing. So let's look at why our factor 10A and PTT level don't jive in this situation. So we've got a high factor 10A level relative to the PTT level. So in this case, this could be effective heparin dose, anti-10A dose of heparin, but an ineffective 2A dose of heparin. It could be the excessive inflammation, which is suggested based on the high fibrinogen and the platelet level. I put factor 8 in here because I was thinking I would measure a factor 8, but we don't have one in this case. And then again, it could be sample integrity. So moving on, you get a tag with heparinase, and this is what you see. So your R time is short, your K time is short, your alpha angle is high, and your maximum amplitude is high.
Caroline, we're running a little bit behind.
Are we running short? Okay.
Yeah,
I thought we would
this
be.
question. The talk is great though.
That's fine. We can move on past this one. We can actually end there, and we can have discussion about those questions during the Q&A session if people have questions.
Thank you.
Let me stop sharing.
Excellent. Thank you so much. That was great. So next, I'm happy to introduce Dr. Susan Shea. So Dr. Shea is an instructor in the Department of Pediatrics at Washington University in St. Louis. She completed her Bachelor of Science in Bioengineering and Biomedical Engineering in 2013, followed by her Master's of Science in Mechanical Engineering in 2016, and her PhD in Bioengineering in 2017, all at the Georgia Institute of Technology. She's an expert in vitro flow models and microfluidics, and uses this expertise to work on clinically translatable projects related to transfusion, the effects of blood product storage, hemostasis, and thrombosis. Among her many areas of expertise, she's interested in leveraging her knowledge of fluid mechanics to understand thrombosis and hemostasis in ECMO circuits. And we're thrilled to have her talk to us today about ECMO circuit-dependent effects of hemostasis.
Thank you. Thank you so much for that kind introduction. Can everybody hear me and also see my slides just to confirm? Thank you. So as Dr. Nair said, my background is in bioengineering, and the mechanisms of thrombosis and all types of extracorporeal support involve really classical material surface interactions and fluid dynamics problems. So I've been thinking about these problems from the engineering point of view, and I'm really grateful for the opportunity to share that with this audience today. So just a really brief overview. I'm going to start with a very high level overview of the mechanisms of surface-induced thrombosis. I liked what Dr. Osment said. It's a drive-by, and I'll continue. We'll kind of circle back into the cul-de-sac and do another drive-by. And then share ways to approach working on this problem with clinical collaboration from the non-clinical side. And then also some benchtop and computer modeling approaches that can also be used. So starting with the mechanistic drive-by. Proteins and biofluids are attracted to artificial surfaces. Upon exposure, they immediately start binding to the surface, and that process is called adsorption. Of course, so this happens when blood first contacts ECMO circuitry, and the surface can change over time due to surface affinity and also protein conformational changes once they're bound. So this adds another layer of complication when considering characterizing surfaces with long timescales of contact, for example, ECMO circuits. So furthermore, what this end biosurface looks like is dependent on the material surface and also possibly the flow environment, which I'll speak to next. But it's this adsorbed surface that is material and flow dependent that ultimately triggers thrombosis via downstream platelet activation and fibrin formation. And this process also has inflammatory effects, of course, which is a whole other can of worms that I won't be getting into today. So the flow environment, we know in vivo is really critical to dictate the mechanism of hemostasis. So back to the coagulation cascade that Dr. Azamat overviewed, that really is dependent on the ability to get to a burst in concentration of those proteins, I think both in the classical model and in cell-based hemostasis. So flow really kind of dictates how this process can proceed. In a low flow setting or low shear, classically venous, this is a kind of diffusion dominated setting. It's easy for these things to achieve burst, and you get this really classical fibrin-rich coagulation clot. When flow increases, there's this convection that starts competing with the burst required to reach these high concentrations. So things get flown away. And so we need other mechanisms that help recruitment here. And this, namely, is von Willebrand factor elongating that enhances capture of platelets. So we know in vivo that flow dictates mechanisms of hemostasis and or thrombosis. So of course, this must be a factor in extracorporeal circulation. So there's two key factors. What I just alluded to is one, the flow environment in the circuit, and there's various flows in the circuit that will dictate both the absorption process, but then also the thrombotic mechanism. But in addition, geometries within the circuit also contribute to flow profiles. So perhaps they cause recirculation, which may increase exposure and residence time, which can also potentiate thrombosis. So when you put those two mechanisms together, this historically has been very challenging to study in a clinically relevant and highly translatable way. And like I mentioned earlier, this really is due to the time scale. So patients can be supported by ECMO and other types of extracorporeal and mechanical circulatory support for days, weeks, months, or even longer. And as we all know, clots don't form within the first few minutes or hours, which is the time scale that's relevant to studying these things in the lab or on the computer. So it presents a challenge, and it just means that these approaches need to be appropriately applied and considered to be put into context. And so far, in vitro predictions about surface compatibility have not always fared well when implemented in patients. So just looking at the short-term surface absorption, for example, doesn't necessarily give the full picture for long-term compatibility. And I mean, I think that makes a lot of sense based on our mechanistic understanding. And I think we can all appreciate that we really need to increase that understanding and have a better appreciation for the combined effects of flows and surfaces and what that means for long-term biocompatibility. That would allow us to better inform on device design, but also to inform on approaches for treatments of current patients using targeted or treatments targeted towards mechanisms. And ultimately, if we can provide better benchtop or computer modeling platforms that are clinically relevant, we can increase throughput to accelerate the development of new technologies. And the FDA, for example, has made a big push to integrate computer models into long-term blood contacting device considerations and approvals, as clinical trials are, of course, really challenging in many of these patient populations. So that was the brief overview. And now just moving on to how I've been approaching these problems, and I think the first two talks alluded to these issues of clot burden in the circuit. And so that's exactly, what I think is a great place to start and really looking at circuits after patient support has ended. So at a few sites now, we've collected circuits immediately after removal of support and catalog sites of thrombosis to really speak to that quantitative incidence. And the objective being to identify the most thrombogenic areas and patterns and problems that are consistent across various patients. So I'm going to share data primarily from two sites, Children's Hospital of Atlanta with our collaborators at Emory and St. Louis Children's Hospital and collaborators at WashU. So the first step in these analyses has been to quantify the incidence of thrombosis. And like I said, to identify these kind of hot spots and problems that are consistent and clearly therefore due to circuitry. And this allows us to provide input and feedback on certain design in treatment and future designs. So one of the main findings, which I suspect will be no surprise to the audience here, is that the connectors in the circuit are consistently a major site of thrombosis. And Dr. McMichael showed that great picture. When you look at it and you shine the flashlight, you can see these clots, especially when they kind of grow into appreciable thrombi. And there's some that are a little more subtle that you wouldn't be able to see with a flashlight. You can see it when you drain the circuit. And we really found that virtually every single circuit I've gotten has had clot in it. So clots form at the edges of these connectors, and they're capable of downstream growth, as you can see on the right side of the screen. And, when I've shared this with clinicians, there has never been any surprise. I think this is well known within the field, but this wasn't necessarily disseminated outside of the field or characterized. And then while we were collecting circuits at CHOA, they transitioned from roller pump to centrifugal pump, and they primarily utilized the Sorin Revolution, which has some interesting design choices, which I'll get into. And when this was implemented, the differences were really striking. 100% of these pumps had thrombosis, with the problem spot being this bearing location right at the pump inlet. So this bearing, it serves as the connection point between the rotational component and the top of the pump. It's this anchor spot. And 100% of circuits, like I said, had clot here, and it was sometimes just a small covering, but in some cases it grew from this point and overtook the whole pump. And we also found that centrifugal pumps increased the incidence of connector thrombosis in the rest of the circuits as well. So it was also increasing systemic circuit thrombogenicity. So like I said, interesting design choices. So the Sorin Revolution leaves a piece of exposed metal at the top of the bearing. And it's also right at the inlet. So this is a region of really high flow speed. And so we were wondering if this is primarily a materials problem or a flow problem or both. But at SLCH, I had the opportunity to collect circuits that had a Medtronic pump, and that bearing location has a similar flow profile, but is covered in plastic. So the incidence here is a bit lower at 70%. That's a pretty substantial reduction from 100%. And it's very similar in formation. So typically has kind of some covering and sometimes grows further into the pump, as you can see at the right. So it seems like it's, the flow perhaps is causing some major problems at the inlet, but also that material selection can influence incidence of thrombosis here. So another way to really go into mechanisms, still using this same kind of circuit dissection approach, is to do histology on the thrombi that are extracted from circuits. So at the left is connector clots or thrombi, and then at the right are thrombi that were taken from that bearing at the top of the centrifugal pump. So connector thrombi look like classic coagulation clots and are very fibrinous. On the other hand, the centrifugal pump thrombi from the Sorin Revolution are irregular, and they have regions of very high platelet content. So from a treatment perspective, this is potentially problematic, as we've now introduced concrete different mechanisms of thrombosis within the circuit that both potentially would need to be addressed. So we've identified other highly thrombogenic components in these analyses. One site uses an SVO2 monitor. This particular SVO2 monitor on the left, about 90% of those have clots that form at their inner edges. And when you consider the fluid dynamics of this shape, it's not necessarily surprising. And we've seen instances where this clot grows downstream into the connector, to the downstream connector. It connects there and goes into the tubing. And consistently thrombogenic at both sites have been silicone bladders. So the connectors potentiate thrombosis here as well, but this surface is thrombogenic. At CHOA, they switched to better bladders, which in our experience of the circuits we collected were non-thrombogenic on the order of 100% to 0% in the better bladders. However, anecdotally, I presented these results and heard from other centers that they've had issues with better bladders. So just wanted to give that disclaimer. So of course, oxygenators are a big concern for thrombosis. The performance of the procedure is dependent on them. So Other groups have certainly shown that clot forms within the fibers and what types of clot form within the fibers. So within the oxygenator is definitely, an area of concern. It's not something that I personally have looked at, but we've seen both large clots that collect or perhaps are caught in the oxygenator, and the inlet side, it's just acting like a big filter. And then we've also seen clot forming directly in the oxygenator, as on the right. So on the left, these clots, if you tilt the oxygenator, they'll kind of slide around. They're not adherent to these surfaces. But on the right, these clots are kind of confluent with the flow going from left to right across the diagonal there, and are adherent. So they've certainly formed there. So also looking at histology on the non-adherent clots in the oxygenator, these are really similar to the connector clots, very fibrinous, but perhaps, we've observed some of this increased red cell content, which are these big kind of orange patches here, which I think supports this idea that these clots are collecting here, they're embolizing from upstream, and then perhaps they're growing and kind of trapping more things like red cells as flow continues. So I wanted to share a kind of tangible approach for how this type of analysis can provide immediate information to inform on circuit layout and design. So this is a sum connector circuit. So we took all the connectors from all of the circuits, and of course there were different layouts, but they're amassed here together into a total incidence representative of each connector type in the circuit. So clearly some connectors are more thrombogenic than others, and this is consistent with this kind of low flow fibrinous coagulation clots we're seeing at these edges. So lower flows are certainly potentiating these. So we see this with the stark differences in the size up connectors. So the upstream would be kind of higher shear rates, faster velocity, and then once that diameter increases, it's lower shear rates and slower velocities. So the flow rate is the same, but those flow profiles change due to the diameter change. And the difference between upstream and downstream is very striking. And also, the large diameter straights versus small straight connectors were more thrombogenic. So this analysis can therefore, immediately suggest in terms of the layout which connectors should be avoided if possible, and which are better to include when selecting a circuit layout if things like access are needed. Another application would be to take this a step further and can use clot incidence and these kind of sum circuits to compare things like treatment approaches or approaches across sites. So of course, ultimate disclaimer, I am not a clinician, but I can still understand that these circuits are attached to patients with their own complexities. And part of the role of these types of approaches, like I've said, is to identify parts of the circuit that are always problematic, as clearly those can be fixed with better design from the engineering perspective. But I wanted to touch on this briefly, just as of course the bedside is a critical piece of the story. So whatever is happening with the patient, of course, can potentiate or attenuate circuit thrombosis. And we don't have a lot of data here, but have some ongoing studies collecting patient data in parallel with circuit thrombosis incidence, to try to pair these analyses and look at links between treatment strategies and outcomes. So from the perspective of flow, I just wanted to touch on this as well, and the types of problems I've been discussing. The matching of circuit to patient can also exacerbate or mitigate these issues. So in the case of the connector, like I said, if low flows are the issue, pairing larger diameter circuitry with low flow rates will further potentiate this type of thrombosis. And we've seen this in other pediatric mechanical circulatory support applications, such as the Berlin heart, going size down or size up. If you have a patient on the borderline, can kind of influence what the flows are in the circuit or in the device. So higher flows in the pump, for example, could also exacerbate that problem. And so that knowledge can be applied to optimize circuit selection and at least, make a tendency towards favorable flows. So lastly, I'm going to touch on the research side of things and speak to approaches both on the benchtop and that can be undertaken using in silico or computer modeling. So we used computational fluid dynamics, or CFD, to look further at these areas that we've identified as thrombogenic. So this goes again to kind of using all of these analyses combined to really get at what is the mechanism that's causing thrombosis at these spots. So CFD models flow patterns and can identify areas where problematic flows are occurring, and thereby provide information into these mechanisms of thrombosis. So consistent with the observations that I've been sharing of fibrin-rich clots here, these edges, so this white space would be the actual thickness of the connector, and as the tubing expands around the connector, it creates these little tiny expansion regions that actually cause super low flows to the point of stagnation. And that's where clot's forming. And when looking at the flow patterns, that's made as something as surprising as the edge of a connector. It's no surprise that these are thrombogenic areas because the flows are bad enough. And then on the downstream side, this region has more room to expand, and so it's actually a larger region and more clot can grow there and also grow downstream. On the other hand, the bearing location in the centrifugal pump is a very high flow and high stress region, so that's consistent with that mixed composition and platelet richness of those thrombi. Interestingly, here, as you can see on the right, pump vein tips also have high stress areas that we don't observe adherent thrombi at that location, but it's very, very similar in terms of stress to this bearing point at the inlet. So perhaps this is a materials issue or speaks to kind of the overall flow profile being important here. But again, just goes back to this idea that there's very different flow profiles within the same circuit, different materials and surfaces, and therefore different, mechanisms of thrombosis that are occurring, increasing the complexity needed to accurately or precisely treat thrombosis in the circuit. So more and more groups are also using in vitro loops to study circuit thrombosis. So this is a way of kind of combating that time scale issue where short-term experiments really just don't speak to long-term exposure, or if they do, it just must be kind of applied appropriately. So this is one, I think, highly translational way to study these problems and mimic the long exposure times incurred by continual perfusion. But then, of course, when undertaking these studies, there's technical challenges. So these require large volumes of blood, which might make human studies prohibitive, and you have to go to animal to get the high volumes of blood. And also you need to maintain the circulating blood so it's still functional. So in the studies that I've undertaken, this involves kind of supplementing the blood to maintain electrolyte balance and mitigate contamination risk, and also using water baths to maintain temperature of the circuit. So we've used in vitro loops to mimic both the connector and pump thrombosis. And in order to validate this approach, we looked for similarities in both location and gross morphologies. So, is the clot forming at the connector edge in the same way that it does in vivo? And yes, it forms at the same place. And same with the pump. It starts at the bearing in vitro and grows into the pump. And then also when you look at histology, and this was all using porcine blood, we also can confirm mechanisms that way. So, the matching the connector clots by histology and also in the centrifugal pump, just to confirm that the mechanisms proceeding in the in vitro loop are akin to those that are happening in the extracorporeal circuit in human patients. Once validated, in vitro loop methods can be applied in a variety of ways. So I think comparing treatments and reducing thrombogenicity is one really low-lying fruit way to proceed. So we also use this to investigate a novel connector approach by means of a proof of concept where the edges are eliminated. And then progressing this design because, of course, you need access in a connector, so it's not enough to just kind of splice the ends together. And then you can also use loops to go towards these mechanistic questions. So we've tried to identify material flow relationships. So depending on the flow rate, you may change which materials do better in different settings. And characterizing that can inform on device design and, again, future treatment. And like I said, you could also test new treatments. You can test new devices. And also look at other coagulopathic issues like acquired von Willebrand disease and other things that might be arising in the circuit. That high throughput benchtop studies could really contribute to development and understanding. So there's, of course, other innovating ways to tackle circuit thrombosis, and there's been some really exciting developments. So coatings are a big one, obviously, that have been in development for decades. So surface modification of materials has long been pursued as a way of making surfaces more biologically inert. So this can be approached both passively, so making the surface less reactive by trying to reduce that adsorption process or prevent protein binding, or actively by coating the surface with inhibitors like heparin. So I think the challenge here is the same challenge when that I've alluded to studying circuit thrombosis at the bench or in modeling, which is this issue of time scale. So it's difficult to know if the surface coating stays on and for how long and still retains the intended effects. And so I think, similarly, coatings have showed some promise, but I don't know that there's, super convincing RCT level evidence that they've improved outcomes or thrombosis. Targeted circuit anticoagulation is another interesting new approach, which of course is implemented in dialysis, but so far ECMO flow rates are prohibitively high. So this is a potential area, I think, for new circuit design, device design, or pharmacological agents, and I think these are the types of problems that engineers in the space like myself would be really excited to work on in collaboration with, clinicians telling us, what the problems are and what is needed. So I hope I've at least been able to convince you that there are certainly things we can do with the circuit that are independent of the patient to impact thrombogenicity. So there are many flow profiles and surfaces in the circuit, as I've described, that are likely inducing different mechanisms of thrombosis, and this can all be taken into consideration for treatment design and circuit layout selection. So some components and layouts I think are really clearly worse than others, but we certainly need more data here. But I firmly believe that this can be optimized and circuits can be optimized. And I've shown how this can be immediately kind of practically applied via reduction of thrombogenic components and layouts in circuitry. And like I've said, this also identifies areas that we can get to work on from a design perspective to produce better devices. And of course, further understanding of underlying mechanism will also inform on this, and also areas for potential drug targets that could also potentially be applied immediately. So we're also working on the link to patient data, because at the end, if it doesn't influence outcomes, it can be difficult to convince people that this is worth pursuing. I think we can all agree that circuit thrombosis is bad, but the data certainly would support that too. So I'd like to end with just some big picture discussion, as I think a multidisciplinary approach is really vital to working on this type of problem. And I think diverse teams need to be actively sharing information to effectively lead to solutions. So from the benchtop side, if we work in isolation, we risk studies and solutions that ultimately aren't clinically relevant or translatable. And I've mentioned some examples, but I think on the other perspective, information is not being disseminated to outside communities. It just reduces the vision on the problem and the number of people potentially working on it. So for example, with connector thrombosis, this is obvious and known to clinicians, but just hadn't really been disseminated to those of us that might could work on solving the problem. So yeah, just with that, I strongly advocate for working together synergistically. That's what is really motivating my career, to increase this visibility. And ultimately, these problems have a really interesting fundamental issues from a variety of disciplines. So with that, I'd like to thank you again for this opportunity and look forward to questions and discussion. And I'd like to add that I've had a lot of great mentorship, including Dr. Spinella, who is in the audience and organized this webinar, and a lot of really talented collaborators and peers, and some of which have moved on to other institutions. And this is both from the clinical and basic research side, but they've all very much contributed to the work I've shared today. So thank you.
Excellent. Thank you so much. That was really excellent. So we're going to move on now to the question and answer session. So just logistically, you can feel free to just unmute yourself and ask questions as you'd like, and you can also ask questions in the chat. So this session will be moderated by Dr. Ryan Barbaro. Dr. Barbaro is a clinical assistant professor in pediatric critical care at the University of Michigan. He earned his medical degree from the University of North Carolina School of Medicine in 2008, and then completed his residency in pediatrics at North Carolina Children's Hospital, followed by fellowship in pediatric critical care at CS Mott Children's Hospital. He is the University of Michigan Pediatric Critical Care ECMO Medical Director and is also the Registry Chair for the Extracorporeal Life Support Organization, or ELSO. His research focuses on pediatric ECMO and outcomes. He is currently the principal investigator of the NIH-funded ARDS in Children and ECMO Initiation Strategies Impact on Neurodevelopment, or the ASCEND study. So ASCEND aims to characterize the one-year outcomes of ECMO-supported children and aims to address the question of if and when ECMO should be initiated in children with severe lung injury. He's also a current scholar and career development awardee in the Advanced Care Through Implementation Science in Cardiac and Lung Illness, or tactical program. So we're very happy to have him here to moderate the session.
Thank you so much for that generous introduction, and thanks Drs. McMichael, Osment, and Shea for really incredible talks walking us through the anticoagulation monitoring and circuit design. And I think remarkably also in an ECMO talk, I felt like each of you made recommendations to optimize care. I think, there's so little known here. I think that's a huge testament to the thoughtfulness of all of these talks, whether that's a lean towards bivalve or multifaceted monitoring approaches that were recommended, as well as some circuit design streamlining. So thank you so much. And we can open it up to the audience for questions, or if not, I can also kick us off with some questions.
It looks like there
Question.
hasn't been any question. Oh, go ahead.
Okay. Yes, so quick question for Susan. By the way, it's a great talk. What are your thoughts about factor 12 inhibition and its effect on thrombogenicity of biomaterials?
Yeah, so I think, all of those approaches, or specifically targeting, for example, the intrinsic cascade, is a really valid approach in biomaterials. I think, as I've kind of alluded to, we just need more understanding as to what that initiating mechanism is, and that could be different, for example, on that bearing surface versus the connector edge. And so, I think if it can be systemically applied and tested, and perhaps that would be something, appropriate to test in an in vitro loop with that long-term surface development. But yes, I think if we can understand those initiating mechanisms, both on adsorption and what the bioactive surface then does to initiate thrombosis, those are great targets to prevent material thrombosis.
Dr. McMichael, I have a question for you. I guess what with regards to like the bivalve versus the unfractionated heparin studies that you reported on, and most of those obviously are pretty small observational studies. You obviously are thinking carefully about doing a randomized control trial and are working towards that. That's fantastic. As we in the meantime, as we sift through the observational studies that are there, how do you think that we're able to interpret those in the setting of these kind of small small sample sizes intermixed with the patient heterogeneity that's obviously seems to be present in all the studies? How have you kind of sifted through that to interpret the outcomes of the studies?
I think most of the studies have shown that bivalve is at least as safe and as effective as heparin, and then potentially could be more safe and more effective. But I think that's what we really need the randomized control trial to actually demonstrate. So I find some solace in the fact that I agree the studies are small and some are combined adult and pediatric, and like I mentioned, a lot of them have different protocols, but most of the studies that we saw were able to see less blood product transfusion, less thrombotic events, and less bleeding events. If they didn't see less, they at least saw equal. So I think that's what we have found so far. I think the hard part, like you mentioned, though, is that it's a wide range of patients that were being used, indications and dosing as well that was used. And so I think that needs to be watched closely when you use it for your own patients.
Thanks so much. Dr. Osment, I guess a question I'd have for you is, in terms of, as you think about how we can move forward towards optimizing, hopefully, some of the strategies for monitoring, you identified, I think, which sounds like a completely rational and agreed upon approach of a multifaceted approach. But how do you think we as a community can reach consensus on this issue, in the face of really, the same kind of small single center studies that are mostly out there, as well as, I think a lot of lack of current consensus on what the right strategy forward is. And so, like, how do we as a field start to agree on, this is the best path forward given the evidence that we have?
Yeah, I think that's super tough. You and I have been working together with Allie and the peace consensus statement group and trying to come up with ideas for this. And I think one thing, I think there are a couple of things that are really tough when it comes to making these recommendations. And one is that the circuit setups are so highly variable. And so it's hard to even know what therapeutic levels of any assay you should be looking at, much less what grouping of assays. Secondarily, I think that many centers are limited by the variety of assays that they can reasonably get. I know that some centers, really do rely more still on ACTs because that's what they can get most readily. And so I think it's going to be tough to come up with exact therapeutic ranges and exact tests, but I guess my hope would be to move towards a goal of using a reasonable multifaceted approach. I don't have a great study, a great study method to propose to be able to do that. But I think, one thing would be really reporting the type of assay that you use in your studies, and whether, your anti-10A assay has antithrombin, and does it have dextran sulfate, and what are the therapeutic ranges for your PTT, and is that measured against protamine titration? I think all of that would be a start towards trying to develop a more streamlined approach to monitoring these patients. But obviously, it's not a quick fix.
Yeah, agree. And so just to expand on what you said in terms of the peace consensus group, led by Dr. Mazinski and Dr. Peter Alexander, who are just, have put together a tremendous team, many of which are here today as well, to help us, at least in the absence of some of this high-grade evidence, at least identify where the areas was we as thoughtful clinicians can agree that this is the best strategy to move forward, and where are the areas actually where we're not able to achieve consensus, and to put forward both of those. It's a fantastic process that's ongoing, and it's been really neat to be able to observe and to be led by Drs. Mazinski and Alexander through that process, and with input from the team.
Ryan, if I could just make a comment.
Yes, please, of course.
Thanks. It's interesting. As I heard the three talks, which were fabulous, and it may be the pessimistic New Yorker in me, but what I heard was from Allie that we're probably using the wrong drug to anticoagulate patients. I heard Caroline say we're probably using the wrong assay to titrate the wrong drug. And then I heard Susan say we've designed circuits in a suboptimal way as well. And we are all, as clinicians, focusing on the last question was, how do we design studies to determine better anticoagulation? I really think we have to start with better bioengineering of the circuits, because until we fix that problem, it's going to be impossible to try to anticoagulate patients, and circuits effectively, to prevent bleeding in the patients and clotting in the circuit. It's kind of, in a way, spitting in the wind or doing something else in the wind. That it's until we solve the problem of the circuit. I think while it's valiant to try to design clinical trials, it's really the main problem is the circuit. And I think there are bioengineering approaches that can be taken that might be able to get us to the point where we could affect clinical outcomes with then better assays that also need to be bioengineered. Susan didn't go into her microfluidic models that she has worked with others at Georgia Tech and further developed. The assays that we use to kind of go backwards now, back to Caroline, are suboptimal, and then we can get to Allie's area of designing trials the right way to determine which anticoagulant is best titrated by the right assay in the optimal circuit.
It's a rabbit hole for sure. Every time I think about it, I fall down another one.
Right, but maybe again, we need to work more with the bioengineers to build the right, to develop the better circuits or the less thrombogenic circuits so that we have a chance to do better with our patients. Otherwise, it's a complete, cluster something. I'm behaving today.
You are.
I'm biased, but I agree.
Dr. McMichael, do you have anything to add as well? I can follow up to that.
I think that's the hardest thing when it's too. It's just everyone uses even different definitions of bleeding. Some centers will use a drop in 2 grams of deciliter for bleeding. Some use, in the adult studies, they use 3. And then defining thrombosis, I think, is really difficult. It's so subjective. What my center will change a circuit for compared to what another center will change a circuit for. So we may see that clot burden, but what do we actually do about it? And does it clinically matter? I think it's really difficult as well. So I agree. I think until we can define what truly it means to be anticoagulated, which I don't think we actually know right now, we're using all different types of definitions. And then what are our risks? How do we define bleeding? How do we define clotting? Then until we can do that, it's really hard to compare the studies. And so I know for our center, we, like Caroline said, we check 5 labs every day, and then we just kind of choose the one that we think makes the most sense for the patient. But until we can standardize things, I don't think we can really do good trials.
We are coming up to the close of the hour, so I do want to be respectful of people's time. I don't know if anybody would like to make any closing remarks before we continue, before we close, but I just, again, thank you to the speakers. Fantastic talks, a really great session.
Yeah, thanks everybody for joining. You can see we have a link here, so please give us feedback about how we can make these webinars better. We'll sort of plan to do a couple of these on different topics related to hemostasis and thrombosis and transfusion, a few of these every year. So if you have suggestions for other topics we could focus on, that would be great as well. And just a really heartfelt thank you to all of our wonderful speakers. This was just so interesting, and it was just great to see all of the thoughtfulness and passion that everyone shared with us with their presentations today. So just thanks very much to everybody.